All right, well, thank you. So in the spirit of talking about workforce development, I wanted to sort of set the stage to talk about how, at least in Southern California and actually the state of California, we've been trying to use a learning collaborative to sort of scale up a particular area of profession, pharmacists and pharmacies, to kind of use it to probably address some of these services need that we've been talking about. So I'm going to set the stage, and in the interest of time, I know everybody wants to have lunch, so in the interest of time, I'm going to skip a few slides, and so I can give Dr. Abrams as much time to actually talk about the California Right Meds Collaborative, which is what this would be. So I'm going to jump to the issue of shortage. As we know, if you look at shortage areas based on state projections, we continue to have a lot of primary care shortage, even in the county of Los Angeles, and also, of course, mental health specialists. And not too surprisingly, it's you see the shortages in sort of South Central Los Angeles historically with under-resourced communities, and also a little bit more north, which is mostly rural communities and rural areas. Not too long ago, we actually had done a mapping study with UCLA, and we tried to look at all sorts of different things: economic hardship, psychological distress, even looking at public-funded mental health facilities, and even looking at health behaviors. And not too surprisingly, there's a lot of needs. People can read a little bit more if you want to know the details, but the same sort of thing: rural areas, under-resourced communities. We also map out, looking at pharmacies and pharmacists, and as you could see from these two maps, they're actually the pharmacy community is actually very much across the region. And so in some ways, they're a very untapped workforce. And part of the intrigue for us, at least when in working from a health department standpoint, is that we're very interested in promoting team care and comprehensive medication management. And that doesn't necessarily have to be in a clinic space or even in a hospital space. It could actually be done sort of in the community. So I'm going to jump ahead and sort of set the stage here. And so one of the reasons is that so the health department, several health plans, and the USC School of Pharmacy actually came together. And we started looking at, can we develop a learning collaborative to basically train pharmacists, pharmacy technicians, to be able to sort of deliver these more team-based care and be creative about the solutions that can be done. And part of this CRMC experience is really a focus on team-based care, where you could actually begin to do comprehensive medication management, and part of that is to improve adherence to treatment. The second part of it is workforce development, right? Are there opportunities to really better train and use non-physician professional, in particular this segment of profession that is probably underutilized, pharmacists, pharmacy technicians, etc. Part of the challenge, of course, is not just running the programs. We need to create infrastructure where you have critical mass of some of these non-physician professionals to actually do the work. And probably more importantly, which has been alluded to throughout this morning, is that eventually we're probably going to have need policies and infrastructure, community infrastructure, to support these type of multidisciplinary teams. So I'm going to stop here, and I'm going to have Dr. Abrams take a deep dive into CRMC.
All right, thank you. I will dive right in. So like Tony Kuo said, this is kind of an innovative model, value-based model of care. Today we heard so many amazing programs and speakers speak about different programs, and two solutions I heard was We need workforce expansion and development to continue to support the growing population, the unmet needs, the staggering numbers that we've heard about, people with mental illness and homelessness. And this is kind of an innovative model that helps fill that gap. Not the only solution, but one that can definitely assist. Why pharmacists? We know medications matter. We know that adverse effects from meds are the fourth leading cause of death in the US, and 75% of hospital readmissions are among seniors in the US due to avoidable medication misuse. So these are not things that couldn't be avoided. They could have certainly been avoided if had those patients had comprehensive med management from pharmacists in their community pharmacies. This results in $528.4 billion of avoidable spending due to, again, misuse or suboptimal use of medications. And just to think about it, 10 people in the US die every hour from preventable medication harm. This is a major reason that we really should look to the pharmacy setting, pharmacists, technicians, other support staff in the workforce and the healthcare team that can kind of work as physician extenders, work in these multidisciplinary teams to help fill the gaps. If you haven't heard of the term before, comprehensive med management, it's really just the pharmacy team looking at a patient, looking at every single medication that patient is on to make sure that it's the right med, it's at the right dose, has it been titrated, has it been increased as it should, and then looking at their other meds and their other conditions and making sure that, a lot of times patients see their physicians and each physician is focused on what they're treating and isn't necessarily looking at the full picture and all the meds. And, can my patient even afford these medications? Can my patient even tolerate these medications? And they continue care with the assumption that their patients are taking their medications, are picking them up, when in fact they aren't. This is just a ton of literature, and there's so much. If you care to look just to see the impact of clinical pharmacists on the care team and this multidisciplinary team-based care. And this slide just gives you another example of what we've seen over and over. When we have PCP-only care, it was taking about 26.7 hours a day to provide all the care they would need to provide to patients. This includes the preventative care, chronic disease care, acute care, and then a little bit of the documentation and inbox management that they deal with in their AHRs. But by shifting to the team-based care on the right, you see that number, 26.7 hours for the PCP to take care of a patient drastically reduces to about 9.3 hours. And a lot of this shift is in that preventative care where you see 14.1. At least 10 hours of that time is around counseling and around other preventative functions that can easily be shifted to non-PCP members of the healthcare team. An example of integrating pharmacists amongst 5,775 patients where we kind of did this comprehensive med management using pharmacists. They were able to find 67,169 problems amongst the medication. A lot of this was in the appropriateness and effectiveness and safety issues. So sometimes it just wasn't the right drug from that class for that patient. It might have not worked with their other comorbidities, might have just been, an antidepressant that was started at a starting dose and never titrated up to an actual optimal dose. So simple primary care area type medication-related problems that pharmacists are definitely trained to help at least assess and address, and then make recommendations to the other members in the healthcare team. So where can we do med management? Really, different settings, but not just the medical clinics, hospitals, et cetera, but really out in your pharmacy. And this is why we're focused on, trying to do this out in the community pharmacies. It's a really great picture to look at because everyone knows how there's a Starbucks on every corner, but there's actually way more pharmacies. So we have 15,149 Starbucks, but 61,715 pharmacies. Pretty much 90% of the US population live within 5 miles of a pharmacy, and then you see the percentages even within 2 miles or 1 mile. And people visit pharmacies often. Seniors are there 12 to 14 times per year, probably more even now. And the non-senior Medicaid patient, actually 24 to 36 times per year. So it is a very accessible, easy to get to place that patients can get to, and that can really serve as a prime kind of health hub that's available to them to increase access to their care. Not just to pick up their medications, but receive that comprehensive med management. And besides being accessible, frequently visited, there's staff there, including pharmacy technicians that are usually culturally, linguistically aligned to patients in the population. And the pharmacies, many times in their community, also have familiarity with local resources, social needs that they can kind of recommend to their patients. You might have seen this picture before, but we know that a patient's health, 80% of it is really due to their socioeconomic factors, environmental conditions, and their own health behaviors like smoking and drug use, diet, exercise. So a lot of this stuff, 80% of the health, can really be taken care of at the pharmacy and promoted and counseled by our pharmacy technicians and other support staff on the pharmacy team. So the collaborative we're talking about is called the California Right Meds Collaborative. This collaborative was launched by USC, and it's basically trying to get all the partners together. So it's a consortium of the health plans, the pharmacies out in the community that USC can train and provide the right resources and tools to be able to provide that advanced level of care beyond just filling their prescriptions and dispensing them. And then also medical clinics, FQHCs, et cetera. So we're really trying to get all the partners together, including the payer, so that the payer can fund these services for these patients. And in our collaborative, there's a lot of training. That's pretty much USC's role in the collaborative, is getting all the partners together, but also training the pharmacies and making sure that we are constantly training them and providing them the resources and taking back to them programs such as today that I learned about that are available to them to kind of triage their patients to and refer their patients to. These are a list of some of our partners actually right now, but many more. We're really trying to learn from everyone and connect all these resources for the patient. We know how hard the healthcare system is, how fragmented it is, and if you're not someone who is already a healthcare professional, or you don't have a family member that is already a healthcare professional to help you navigate, really that's what we're trying to do in these community pharmacies. Have patients go there that otherwise seem a little lost or otherwise don't know where to go for different resources, and can really get all of that at their pharmacy versus worrying about just not getting the information or care they need. Just to talk about impact a little bit, I'll go straight to our impact. So when we first launched the program, we basically met with health plans to see what are your pain points? Where do you need help? And we started it with the LA Care Health Plan, and their area was diabetes. So just in the patient population that we did this with for diabetes, we had an average A1C drop of about 3.3%, average systolic blood pressure drop of 34 micrometers, systolic and 11 diastolic, and then 89.4% of patients with diabetes, if they should be on a statin for heart attack and stroke prevention, were put on a statin. So just clinical outcomes around those areas, I know not mental health related, but those areas alone drastically decreased. And then that's why recently now what we're seeing also is a cry for help in mental health area. So what we're doing in our trainings now is having full day trainings around mental health as well, just to make sure that these patients that might be coming in for diabetes or other conditions are also being triaged correctly for their mental health concerns. So with that, I know I'm done with time, and really that's, I think, the majority. I don't think I have, yeah, this is Inland Empire. We kind of did the same thing around asthma, and again saw those staggering results. So this was my last slide. Just what are we doing next? We're continuing to talk to health plan partners and increase, the ability to pay for these programs, integrating a psychiatry for population health collaborative to help train our pharmacies in mental health so that when these patients come, they can really look at the full person and give them that whole person care that they need. Thank you.